Thanks again for the opportunity to speak today. No disclosures. We'll be talking about the publication of literature for aortic dissection, type B aortic dissection. And you can see over the years, since 1993, there have been thousands of publications, and you can see how that curve is really ramping up in terms of our ability to produce data related to type B aortic dissection. Okay. No matter how hard I press. There you go. Despite thousands of articles generated, again, questions remain. Is early TVAR appropriate in acute aortic dissection? What timing is best for intervention, and what early features portend a poor prognosis? We still don't have a good understanding of these questions. And let's put type B aortic dissection again in context relative to those questions. And I think what we're really asking is, when is intervention necessary versus when is intervention prudent? And to answer that second half of the question, we first formulated a backbone of language and how we describe type B aortic dissection with the reporting standards published in 2020. And we used a comparison of complicated versus uncomplicated and defined them as such. Complicated is malperfusion and rupture, and uncomplicated is no malperfusion, clinically or radiographic, no rupture, and no risky features, and we'll get into that. We really needed to create a separation of one extreme versus the other. And for complicated type B aortic dissection, what we know right now is intervention is necessary, and TVAR remains the gold standard for that situation. And we know the efficacy of TVAR has been well described in the literature in this context. So what about acute uncomplicated type B aortic dissection? Well, the literature is less convincing. You had the ABSORB trial, which really failed to delineate a difference in a prospective randomized fashion. We have new trials that are going to help us answer these questions on board, and hopefully can give us a little more information. But what we know about treating acute type B aortic dissections that are uncomplicated, type B or acute dissections have the highest stroke rates. They have the highest rates of retrograde type A dissection after TVAR, highest rates of paraplegia based on stable data, and also no benefit demonstrated with early TVAR whatsoever, other than anecdotal single institution data. So uncomplicated, in my opinion, is TVAR is very risky if it's truly uncomplicated. And how about the subacute variety? Doesn't early TVAR promote better remodeling in these subacute patients? Well, we did a systematic review looking at early TVAR in this setting, and we did robust measurements and a meta-analysis. Could you advance the slide, please? 84 publications met these inclusion criteria, and we had 1,100 patients in the thoracic aorta, and the abdominal aorta was about 400 patients, and we concluded that early TVAR did not prevent aortic growth in these situations. We definitely have to include INSTEAD data when you're looking at the subacute patient population, and found that there was no difference in survival with INSTEAD 1, although INSTEAD XL did show, when you teased out the first year of complications from TVAR, there was a benefit to early TVAR for these patients. So when we look at complicated versus uncomplicated, when you have an uncomplicated patient, I think it's an easy decision right now, and that is having the patients maximized on medical therapy, and I consider that an easy decision. As far as complicated dissections are concerned, I think they should be treated, and early TVAR from that setting is paramount. Again, that's an easy decision, but everything in the middle is very complicated. And that's where the reporting standards document delineated a third category called high risk. And in this category, we wanted to define features, both radiographic and clinically, that portend a poor prognosis based on available data at the time. And what we had found that all these high-risk features had substantial evidence to include and give pause for patients who presented in this fashion. Refractory pain and hypertension has an astounding rate of mortality for patients that had, this is not advancing, 35.6% mortality in less than 30, in-house mortality in 30 days compared to those who did not. Bloody pleural effusions, mortality rate of nearly 16% compared to those who did not. Increased aortic diameter at the time of a diagnosis, again, portended a high mortality, and readmissions also portended a high progression to complicated type B aortic dissection. And then we have lesser curve in the entry tear, again, an independent predictor of complicated decompensation, and also false lumen diameter greater than 22 millimeters. All in all of these portended a poor prognosis and something we consider to be front and center for ongoing research regarding type B dissection. So the truly uncomplicated type Bs are managed best with medical therapy, with complicated as TVAR with the new gold standard for treatment. And high-risk category demonstrates target scenarios for potentially early TVAR. Thank you very much.